Very good afternoon to all of you. DXA stands for dual energy X-ray absorption metric. It's used to diagnose osteoporosis. Now, I require an honest opinion from the audience or a raise of hands. Have anyone who ever prescribed a DXA? If you have, please raise your hand. So, the usual culprits raising their hands. Again, just because we are endocrinologists does not mean that we are the only ones who should ask for a DXA. I asked Dr. Rajan and I learned that there is a center where DXA is available in Durgapur as well. Now, if I ask you, have any one of you ever seen a patient with osteoporosis? How many of you raise your hands? Good, at least awareness about osteoporosis more. I would say all of you have possibly seen a patient with osteoporosis and seen it in the last week itself. I'll just give you an idea. So we get an elderly patient who comes to us with low back pain, and on the X-ray we find that there is a D12 compression fracture. She doesn't give an history of trauma. She's advised to take a calcium and vitamin D supplement. How many of you think she has been properly managed? Just raise your hand. I'm not going into DXA, I'm going into the management part. Do you think she has been properly managed? So good, no one is raising their hand. Everyone feels that there's something more to the story which will come soon. So what is osteoporosis? When we talk of the bone, we need to realize that it's not entirely calcium and phosphate. 70% of the bone is calcium and phosphate. 30% of the bone is collagen, predominantly type 1 collagen. Now, osteoporosis is a systemic skeletal disease where there is a defect in the bone mineral density part, that is the calcium and phosphate part, as well as a defect in the microarchitecture of the bone, the geometry of the bone, the trabeculae of the bone, which is predominantly made of type 1 collagen. So there are two components to it, which in turn result in an increased risk of fracture. So just as we have cardiovascular risk factors in diabetes, which we target to prevent the heart attack, similarly we have certain risk factors in certain patients at risk of fracture, which we target to prevent the fracture. Just like the heart attack needs to be prevented, the fracture needs to be prevented. Why does it need to be prevented? Osteoporosis is a much more common condition than we realize, because 1 out of every 2nd elderly woman and about 1 out of every 5 men will suffer or might suffer osteoporotic fracture in their lifetime. But unfortunately, few of these are recognized, they are left untreated. Most of us have relatives who have had a hip fracture after a fall in the bathroom, or a Colles fracture after a fall in the kitchen. They underwent surgery, but tell me how many of them have received a proper anti-osteoporotic therapy? Very few of them. The problem with osteoporosis, just like the problem with heart attacks, is it kills. It's a mortal disease. About 1 in 5 might die within a year of hip fracture, and if they are lucky enough, if you call them lucky enough, to survive it, about half of them will remain dependent on others for the rest of their lives for activities of daily living. Now, how do we diagnose osteoporosis? Again, for example, if you are sitting in a remote corner of West Bengal, and if you do not have access to DXA scan or DXA scan, you can still diagnose osteoporosis. Just like a patient who has had a heart attack does not need an ECG to diagnose ischemic heart disease. Similarly, someone who has suffered a fragility fracture already has osteoporosis. You need not do a DXA to establish the diagnosis of osteoporosis. So what is a fragility fracture? So if you fall from your standing height, that is you are standing and you slip and you fall, and you fracture one of your long bones or big bones, that is a fracture which is not a fracture of the skull or the digits or the ribs for that instance, a fracture of any other of the long bones from a standing height qualifies as a no trauma fracture. If you have access to DXA, of course, that's the gold standard for diagnosing osteoporosis. I'll come into the details later. Biopsy is something which is done only in research settings. Now, what does the DXA machine actually do? Simply put, it's a glorified X-ray machine. It is a machine which releases 2 different X-rays of 2 different intensities. The photon beams are of different energies. And as they pass through the bone, depending on the density of the bone. So the denser the bone, the more the electrons, the less photons pass. The less dense the bone, the more photons pass through it. And depending on the difference in the passage of the two different energy X-ray beams, you can use a software to give you the bone mineral density. This is how the report looks like. You have images where L1 to L4 is mapped, the region of interest, and you have images where the hip is mapped, including the femur. But the main part of the DXA report, which gives you an idea as to whether there is osteoporosis or not, is the yellow colored table at the bottom. And if you enlarge it, there are two values which you need to keep your eyes on. One is the BMD, or the bone mineral density, expressed in grams per centimeter square up to 3 decimal points. And the second is what we call the young adult T-score. So what's the young adult T-score? So the T-score again is the bone mineral density of an individual. Say a 16-year-old woman has a certain bone mineral density. If you compare this bone mineral density with the bone mineral density of a young healthy female from the enhanced 3 study of USA between the ages of 20 to 29 years, and you get the number of standard deviations that this person's bone mineral density is different from that young female's bone mineral density, that gives you a T-score. So your bone mineral density compared to a young female, white female, the number of standard deviations is different, is the T-score for that individual. Now, how do you use the T-score to diagnose osteoporosis? So if your T-score is less than or equal to minus 2.5, you have osteoporosis. If it is less than or equal to minus 3, or if it is less than or equal to minus 2.5, with a history of fragility fracture, you are said to have severe osteoporosis. A value between minus 1 to minus 2.5 is considered to be osteopenia. Anything greater or equal to minus 1 is considered to be normal for that individual. Now, in the BMD report, you get an additional value called the Z-score. So, when you are considering younger individuals, less than 50 years old, or even in children, you compare their bone mineral density to someone of the same age and the same gender, and the standard deviation that you get gives you the Z-score. A Z-score which is less than minus 2 indicates low bone density for age, but you cannot classically call this to be osteoporosis. You rather qualify it as low bone density for age. When I'm talking of the SD levels, I'm saying that minus 2 is low bone density or osteopenia. Minus 3 is severe osteoporosis. We need to keep in mind that this change in SD translates into a change in fracture risk exponentially. For example, if you look at this figure, someone with a bone density of minus 2 has a 5% risk of fracture, increased risk of fracture, whereas someone with a bone density of minus 3 has a 10% increased risk of fracture. So with one SD decrease in the bone mineral density, your risk of fracture can increase by double. It doubles with every SD decrease in the bone mineral density. We have to be very careful regarding the value that we are looking at. So when we look at the DXA report, there are certain tips and tricks that we need to be aware of. There are certain fallacies, there are certain false positives and false negatives that might alter the interpretation of the report. For example, if you look at this report and if you look at it carefully, we find that if you look at the T-scores, at L1 it's minus 1.8, at L2 it's minus 1.5, L3 it's minus 1.2, at L4 suddenly it becomes 1.7 plus 1.7. So minus scores in L1, L2, L3 suddenly it becomes plus in L4. So what has gone wrong? If you look at it carefully, at the L4 level, you see an area of sclerosis. The area of sclerosis, which actually represents an old fracture and sclerosis, which falsely elevates the bone mineral density. So you have to look at your region of interest carefully, and if there are areas of excessive sclerosis or excessive lucence, you have to leave them aside and include only the other vertebra while interpreting the DXA report. Now, the most important question, in which individuals should you get a DXA done? So, any individual who suffers a fragility fracture already has osteoporosis, but to establish a baseline, just like we do a coronary angiogram to look at the degree of obstruction in ischemic heart disease, Similarly, to establish the degree of defect at baseline, we need to do a DXA. And it will also help us when we are treating them, we will follow up to see whether changes are occurring in the positive direction. All women above the age of 65 years and or above the age of 65 years, men and or above the age of 70 years need to get a DXA scan. And if you look at the number of patients who come to us above these age groups with diabetes, hypertension or whatever problem, a good number of our patients will qualify for a DXA scan as per standard national and international guidelines. In someone who is younger, say between 50 to 65 or 50 to 70 years of age in females and males, if you have high risk of fractures, you need to get a DXA scan. Someone on glucocorticoid therapy, someone who is a smoker, someone who complains of progressive loss of height, someone who has progressive kyphosis, someone who is on androgen deprivation therapy, someone who is on an aromatase inhibitor. So if there's an increased risk of fracture, you need to get it done early. When we are talking of DXA, we are using X-ray beams of two different intensities, carrying photons of two different intensities to calculate the bone